Good morning. I'm Eric Swanson. I'm a plastic surgeon in Kansas City, and I'm going to talk to you about preventing blood clots in plastic surgery. In fact, this is my first podcast, and you might wonder why this topic. And the reason is it's an important topic in all of surgery because it's an important safety consideration. So I'm very interested in evidence-based surgery. In fact, I've written a couple of textbooks on this topic. We really have to look to science in order to guide how we treat patients. So my interest in this topic started back in about 2013 because there was a study that was published. The main author was Panucci, and the study suggested or recommended that surgeons start giving anticoagulants to patients after surgery to help prevent the risk of blood clots. So what happened? The Surgeon General in 2008 recognized that there was a problem with patients, not just plastic surgery, but all types of surgery, developing blood clots, which could be a deadly complication. So the idea is, how can we prevent this? So this study was funded. It was called the VTEP study, and it was funded to look at whether giving patients anticoagulants could help the reduce of a blood clot happening. And this paper was published in 2011. The thing that a couple of things concern me. First of all, here I am in practicing plastic surgery, and I'm being told, give anticoagulants to my patients. So, for example, let's say I'm doing an abdominoplasty, a tummy tuck, give that patient something to interfere with their body's ability to form blood clots after surgery. So, of course, I'm concerned about that. For years, we'd been telling patients don't take aspirin around the time of surgery. I was concerned about creating bleeding problems. And I looked at this study and I looked at the conclusions, and I noticed that the conclusions were not supported by the study at a significant level. In other words, patients that were deemed to be at higher risk, they really didn't have a significantly reduced risk of a blood clot after surgery on anticoagulation compared to patients that were not treated with anticoagulation. So that got my attention right away. There was a graphic in the study showing that what it looked like was that patients that were at higher risk had a reduced risk if they took anticoagulation. And this was something called Lovenox, which patients would inject. And yet, if you really dug into this and looked at the data, it was not significant. The differences were not significant. In fact, this problem happened across patients with all different risk levels. And by the way, the Caprini score is what has been used to assess risk levels. And this is it's made up of 40 different factors. And the idea is the more of these factors that you have, the higher the risk. So what the authors did was they distributed patients by Caprini score. And then, as I mentioned, the ones that had higher scores, they determined that those ones had a lower risk if they took anticoagulation. The problem is the data really didn't support that at a significant level. In fact, the patients overall, the patients who were not anticoagulated, their risk was about 1%. The patients that were anticoagulated, the same. So you might wonder, how did the authors come to that conclusion that anticoagulation is affected if it's the same risk for both treated and untreated patients? So what the authors did was they adjusted their analysis. So, for example, they looked at the length of hospitalization and they found that the patients in the earlier control group had a little shorter period of hospitalization, so they adjusted their data for that. But there was no correction for the fact that patients had longer periods of anticoagulation in the hospitalized patients. So basically, they're adjusting their data to fit the theory rather than adjusting their theory to fit the data. They knew what they wanted to find, and that affected how they analyzed the data. Okay, let's switch a little bit. What are important factors for blood clots? You know, one of the most important factors is what kind of anesthesia you have. So for decades, many patients having surgery, they've had what's called a general endotracheal anesthetic. that means that the patient is paralyzed, they've got a tube down their trachea, they're on a ventilator that's breathing for them during surgery, they're given gas. So that's called a general endotracheal anesthetic. Now, an alternative form of anesthesia, it's called local anesthesia plus IV sedation, or total IV anesthesia, or TIVA. And in this type of anesthetic, the patient is still asleep, but the medication is given totally intravenously. They don't get gas, they get intravenous medications, and they're not paralyzed. So they're actually breathing on their own spontaneously during surgery. And it turns out that when you look at big studies where patients undergo this type of anesthetic, they have lower risks of blood clots. So what I mean by blood clots are blood clots that form in the legs, and they're a problem because sometimes they can create or cause pulmonary emboli, which can be a fatal complication. So it turns out that patients, if you avoid a general endotracheal anesthetic, you reduce their risk. Fortunately, in plastic surgery, we can do that. Now, I wrote a paper, it was published just last year. I called this new form of, it's called chemoprophylaxis, but basically giving anticoagulation, and the idea is to reduce the risk of blood clots. I call it bloodletting 2.0, and that's an intentionally provocative title because bloodletting, as you probably are aware, it was a very common practice for hundreds of years. It was used right up until the mid-19th century. So what surgeons did, in fact, it was the most common thing that surgeons did, the most common procedure. They would actually take a kind of a knife and cut into a vein and cause bleeding with the idea that this would release evil humors from the patient. Totally unscientific. But this was done for hundreds of years. Even in patients whose problem was a lack of blood volume, they might be injured in battle, and even those patients were given this bloodletting. So terribly harmful procedure, but it was still the most common procedure done. And this was despite the fact that we were well aware of the scientific method since the time of Galileo in the 1600s. In other words, medicine was lagging way behind in terms of adopting the scientific method. Should not have been doing this bloodletting, but it took a long time for it to disappear. And in the 19th century, a lot of surgeons, this was just like gospel. It was very hard to stop people from doing this. So if you look at today's chemoprophylaxis, which I told you that's, in my opinion, a new form of bloodletting, and you look at the old bloodletting that was done years ago, there's an unfortunate number of parallels. It causes bleeding. Patients are told it would help them. The harmful effects are minimized. There's all kinds of institutional authority. The scientific method is overlooked. And it's now, some people even consider it the standard of care, despite a very weak basis in evidence. Now, this wouldn't be such a big problem if there were no harm in giving people anticoagulation. But of course, there is harm in giving people anticoagulation. Hemorrhage is actually the most common adverse reaction associated with enoxaparin, Lovenox, which is this medication that's often prescribed by doctors for patients to inject themselves after surgery. In fact, there was a study by some authors in Brazil. They had to discontinue the study. It was randomized, it was prospective, but they found that too many patients were having bleeding, and they determined that those were the patients that, of course, were taking the anticoagulation. So they were having a high incidence of bleeding after surgery. Now, this contrasts with, for example, my own study where I evaluated 310 of my own consecutive patients who had abdominoplasties, and I never used chemoprophylaxis. None of them had a hematoma. So I regularly get communications because I've written a lot on this subject, and plastic surgeons will send me emails. One I got that said, "I very much enjoyed your article in PRS Global about the Caprini scale. I almost lost a patient after he nearly bled out with Lovenox." And the author thanked me for exploring this important topic. Years ago, there was a scare story in our newsletter, plastic surgery newsletter. It talked about a patient tragically died about 3 or 4 days after a mommy makeover. The surgeon's competitors rallied against him. He was accused of failing to perform a risk assessment, which is that Caprini score, and failing to prescribe anticoagulation, which could have allegedly saved the patient's life. So the surgeon lost his hospital privileges, his practice, his wife left him, he attempted suicide. So another victim was added to this tragedy. And of course, the family now blames the surgeon. So it's really increased, this practice has increased our liability. And a lot of surgeons, they go along with this practice because they don't want to be at risk legally. And some plastic surgeons have developed a side hustle, acting as a paid plaintiff's expert. In fact, earlier this year, I defended a doctor in California. His patient tragically died of a pulmonary embolism the day after surgery. The board found an expert, a board-certified plastic surgeon, to testify that his practice was negligent, and they threatened to take his license away. So we have to be very careful about this. In fact, some surgeons, they'll decide to settle a lawsuit for insurance limits. It could be $1 million, rather than risk going to a jury. And, there's always an element of risk with the jury in terms of they may award a large settlement because a poor patient died, regardless of the fact that the doctor was actually operating or practicing within the standard of care. So one deposition that I read, the doctor said, I think it's a deviation of the standard of care. And if the doctor had not prescribed this anticoagulation, or if he had, it would have prevented the patient's death. And that patient that I mentioned that I defended in California earlier this year, her Caprini score was quite low, but the expert concluded that even in this situation, it was a deviation from the standard of care. And again, the doctor's license is being threatened. So we need to look at Caprini scores, like where did these come from? Well, these were actually developed, the doctor's name was Joseph Caprini, a general surgeon. 2005, he published in a journal called Disease a Month Journal, which is a primary care journal. It's low impact. In other words, it's not read very much by doctors. He had only 24 references in his article, and none of these references supported his scores. In fact, he based his scores on his criteria, which were logic, emotion, experience, and intuition. What he didn't say was that he had numerous undisclosed financial conflicts with anticoagulant manufacturers. So very unscientific basis for this widely used scoring system. So I looked at, in 2016, I published a paper, I looked at Caprini's scores versus relative risk from medical journals. These are papers published in medical journals to see if they correlated. Turns out there wasn't a correlation between Caprini scores and relative risk. So, not surprisingly, it really has failed to perform. In several studies, the false positive rate, if this were a screening test, we talk about, for example, a screening test, what is the false positive? It should be low. There should be few false positives. Well, it's 97% in 3 large studies. In one study, 36 patients with super high Caprini scores had no evidence of VTE. And VTE, those are blood clots, either deep venous thromboses or pulmonary emboli. And there was a study, the main author, her name was Lemaine. She found that 97% of the microsurgical breast reconstruction patients with the highest scores had no evidence on ultrasound of deep venous thromboses. So clinical evaluation is inadequate. You really have to use ultrasound if you're interested in knowing how many of your patients are developing this problem, because as Lemaine found, she found that there were 9 suspected cases where the patient had some swelling or some soreness in their leg and no evidence of a blood clot on ultrasound. And there were 4 that were present in patients that had no clinical signs. So if you want to study this problem, you really have to be doing ultrasound on your patients. And I've talked a lot about this. So in Brazil, I mentioned this, the authors used an oral form, Xarelto, in an effort to reduce VTE risk, but that's the study where I told you they had to stop it because so many patients were developing bleeding. Now, these are not just an inconvenience. This bleeds. The hemoglobin level drops. The patient may become symptomatic because they've lost blood, and they have tremendous bruising and swelling. Sometimes the skin will die. Sometimes they'll need a blood transfusion. It can risk the aesthetic, the cosmetic result, because you can have areas that take a long time to heal. So they're not just inconveniences at all. They really totally change the patient's experience after surgery. So we don't want bleeding after surgery. Now, I do just about all my surgery I do as outpatients. We don't want a patient to experience this problem as an outpatient. Now, there was a study that was published in one of our journals in 2021 suggesting that there is no increased bleeding risk with chemoprophylaxis. The problem was the authors excluded a couple of studies, that one in Brazil that I mentioned. They also excluded a big study in France with over 1,000 patients where they found that they had 64 hematomas or bleeding episodes in abdominoplasty patients for an incidence of 5.7%. Remember, in my study, it was 0. So if you include these other studies that the authors didn't include, there's a highly significant increased risk of bleeding. So I mentioned I got very interested in this years ago. In 2013, I purchased ultrasound equipment, and I started having my patients scanned before surgery, the day after surgery, and about a week after surgery. So I started to incorporate ultrasound screening in my office. And as I mentioned, my patients have total IV anesthesia. They're not paralyzed. We don't want to paralyze them because we think if we paralyze them, we increase the risk of blood clots in their legs because the calf muscle pump is being paralyzed. So we don't do that. So over the period of my study, which was a prospective study, it was published in 2020, there were 9 DVTs, 1,000 patients. So this was just under 1%. 1 pulmonary embolism, no deaths. Now, the patients that did develop blood clots, those patients were anticoagulated. And we found that the mean or the average time for the blood clot to be cleared up was 5 weeks. We would follow them along in the office and do scans to make sure that the blood clot is dissolving. I also had a biostatistician look at all of this data. And it was very interesting. We found that the only independent risk factor for blood clots was the patient's age. As patients got older, their risk increased. So I was also interested, there's been an idea that if you put compression devices on your legs during surgery, after surgery, that could reduce the risk of blood clots. And it kind of makes intuitive sense that if you put these devices that squeeze on the calves, then maybe that would prevent blood clots from happening. They're very commonly used. There's another idea that just using these devices could have what's called a fibrinolytic effect, but reduce the risk of blood clots because of affecting the tissue plasminogen activator levels in the blood. In other words, making them less prone to form clots hormonally through release of this substance that's in the lining of vessels. So I looked at that. I did a randomized study where we did blood tests on 50 consecutive patients, and we found that really these devices had no effect on the TPA levels or the plasminogen activator inhibitor levels. So basically, this theory is not true. In that large study that we did of 1,000 patients, we found that the first half of the study, patients did get these devices, and the last half they did not. There was no difference in risk. So whether we found that these devices, they're not helpful. So I don't use these devices. In fact, there's even some evidence that they might interfere with venous drainage. So basically the message is for the type of anesthetic that this total IV anesthetic in outpatients is not a helpful thing to do. Now, what about risk modification? There's an idea that, okay, let's see if we can reduce risk by doing certain things. One of them is during surgery, flexion of the operating table. In one of my speeches, I talk about how during an abdominoplasty, I like to flex the operating table to assist in closing the wound so I can keep the scar very low. And some people think, well, if you flex that table, that position, that jackknife position, maybe that can interfere with venous drainage and increase the risk of blood clots. Well, that turned out not to be true, because we found the day after surgery, we found almost no evidence of blood clots the day after surgery. So that did not appear to be true. What about repairing the muscle? We want to usually repair the muscle during a tummy tuck because it's so helpful in terms of, women who've had pregnancies, the muscles have been displaced. If you bring them together, it really helps correct that problem. It brings the abdomen back almost the way it was before pregnancy. So it's a very helpful thing to do. But there's some doctors who think, well, maybe that increases the risk because of creating like a bottleneck effect, like you're putting pressure and that can affect the venous return to the heart. So the idea is, well, maybe avoid doing that, or avoid using hormones, because a lot of women, they're taking oral contraceptives, they're taking hormones to prevent premenopausal symptoms. So what about stopping that? Or what about not using a compression garment? So these were all ideas, things we could do to reduce risk. It turns out that none of them is supported by evidence that we found in our study. So let's get back to Caprini scores. There's a big study. The main author was Keyes in California. They looked at actually thousands of patients that had tummy tucks, and they found that the Caprini score was low, was actually 6 or lower in 89% of patients who had blood clots. So really, this fit in with the other evidence that Caprini scores really are not helpful in identifying who's going to develop a blood clot. In fact, if you look at a Caprini score, if a patient has a score of 7 or greater, they have a 2.5-fold increase in risk, like 3% instead of 1.2%. Well, it turns out if you just look at the patient's age, if they're over 50, they have a 3-fold increase. So even just looking at the patient's age is more helpful than a Caprini scores. So most surgeons, even those that advocate Caprini scores, don't actually use them on an individual basis in dictating management of their own patients. And asking about miscarriages, some doctors believe that this is part of the Caprini score, provides no useful information. It can be uncomfortable for women to discuss. So ultrasound is a much better use of 20 minutes than evaluating a Caprini scores. Back to that idea of that abdominal pressure, there's actually a study, I'm getting into the weeds a little bit, but there was a study comparing abdominoplasty patients with breast reduction patients, and they found there were no significant difference comparing the abdominoplasty patients with this control group in terms of their pressures, and they were all under 20 milligrams of mercury, which is deemed unimportant clinically. So I just wrote a study recently. It's just actually it's actually just published just last month, but showing that the effect of repairing the abdominal wall does not affect the risk of blood clots. So it's a good thing to do, and it improves the result, and it would be a shame not to do it because it's so helpful for patients. So my approach, we have to recognize that it's not possible. The idea that we can predict affected patients, it just hasn't worked out. We have to admit it, that we can't predict who's going to develop a blood clot. We can do some things to help reduce risk, like avoiding muscle paralysis to preserve the calf muscle pump. But there's no need to put patients on anticoagulation because most of these patients are not destined to develop a blood clot. And it does increase the risk of bleeding. We don't want to do that. And these courses are usually just a week. Even if a patient was going to develop a blood clot, they're going to need to be on anticoagulation for, as I mentioned, at least 5 weeks. Typically, we'll have them on anticoagulation for 3 months. There's no need for those sequential compression devices. I advocate using ultrasound surveillance. I think it's a useful thing to do, not just in plastic surgery. If you find a patient with a blood clot, you can get them started with oral anticoagulation, and that will help prevent it from becoming propagating. We say it propagates, it gets larger, but that'll help to prevent it from propagating and becoming a larger blood clot that if it breaks off, it could be a life-threatening pulmonary embolism. So what we need to do is emphasize early detection. The good thing is blood clots, first of all, they don't tend to happen during surgery. They tend to happen about a week later. That's when we usually detect them on ultrasound. But they tend to be small at that point. They're located more distally in the calf. And if we start anticoagulation at that point, it appears that we can help reduce the risk of them propagating and becoming bigger and possibly causing a dangerous pulmonary embolism. In fact, there's a YouTube that in 2015, a YouTube just showing in my office doing ultrasound. It now has, the last time I checked, it had 268,000 views. So this has really created a lot of interest among plastic surgeons and others. There are only about 7,000 board certified plastic surgeons. So obviously a lot of other doctors and probably other medical providers are looking at this YouTube. So, but patient safety, we all talk about it, but we really have to walk the walk, not just talk the talk. And this is an important way of doing that. It's good for business. Check with your anesthetist, see if they can avoid paralysis and do a total IV anesthesia. Where ultrasound is so useful, especially in a plastic surgery office, start incorporating it, checking patients for blood clots. Patients don't really want to inject themselves with anticoagulants after surgery. It's uncomfortable, it's expensive. They don't have to do that. Another thing, during surgery, I don't position my patients face down. They're always up or on their side. No need to position them prone. And I use long-acting local anesthesia during surgery to reduce anesthetic medications that I have to give after surgery and reduce blood loss. Patients feel better when they wake up. They spend less time in the recovery room. It's safer, less risk of nausea, quicker recovery. So it's all about safety, what we can do to make this experience as safe as possible for our patients. Thank you.